Thank you very much. Yes, I think we've learned a lot about malnutrition already, but I want to come back to this topic because I'm an internist, and I think we do have a lot of overlap in our patients we see in the hospital and the patients you see in the geriatric wards. And I think this is like a typical patient we would see. About 20 to 30% of our patients present with a phenotype of malnutrition. And I think despite this high number of patients, we still have a lot of questions. What's the best diagnosis? How do we best manage these patients? How effective is nutritional care in these patients? So one, I think, very important question is, why do patients actually become malnourished? And I think today we have learned that this is a quite complex pathway that leads to malnutrition. It's not just one pathway, but it's different factors. It's chronic disease, it's older age, it's also acute disease. Then, of course, we have learned that systemic inflammation seems to be one of the key drivers, because as we all know, when we are sick, when we have an infection, a cold, we do not eat because the cytokines in our body tell our brain we should not eat. It tells our guts not to work, and also it tells our cells to become insulin resistant, and so nutrients not even enter the cell if we eat and have food in our blood. And then also we have other factors. We have endocrine changes in the different hormone levels, immobilization, and all this together leads to this phenotype of malnutrition, of catabolism, sarcopenia, and frailty, as we have heard before. Now, there is still a lot of talk about, well, what's now the best definition of malnutrition? We talk about GLIM criteria a lot. I learned today that there is also the Global Leadership Initiative on Sarcopenias, the GLIS criteria. So it's a lot of talk about diagnosis. And I think diagnosis is important, but more important maybe from a clinical perspective is treatment. Are patients actually improving outcomes if we treat these different conditions? Now, in terms of malnutrition, we do have several risk screening and assessment tools. I think you know probably most of those. They are validated tools in different settings, and they can tell us whether a patient is at risk for malnutrition, but they do not necessarily tell us if a patient will respond to treatment. What we do know is that most of these scores have been developed based on prognostic information. And you can see here data of NRS 2002. This is the score we use to screen patients. And you can see that the risk of mortality is increased the higher the risk of malnutrition. So these are excellent prognostic scores, but there is some question, well, do patients actually, if they have a risk for malnutrition, do they respond to treatment? And I think this is a very important question when we work with these patients. And this is also the reason why we started the EFFORT trial, and EFFORT stands for Effect of Clinical Nutrition on Functionality and Frailty in Medical Inpatients. And it's a trial that essentially asks the hypothesis, if we use the best nutritional care we can in the hospital setting, do patients show a benefit beyond the benefit of nutritional markers? So do they show a benefit in regards to severe complications, in regard to mortality? So what is the best nutritional care we can provide? And I think this is also a question that is not so easy to answer, but we try to come up with a nutritional algorithm in this trial where we try to come up with an individualized nutritional algorithm to provide optimal care. So in our algorithm, we had like 3 major points to consider. The first one is caloric requirements. So what is the caloric requirement? And we used in this trial Harris-Benedict equation, but I think you can also use easier standard equations like 25 calories per kilogram per day. You have to use optimal weight, particularly in an overweight or underweight patient. Then the second question was protein requirements, and I think here most experts agreed today that we need to go and aim for high protein requirements, and you see we use 1.2 to 1.5 grams proteins per kilogram body weight. Then also we had micronutrients where we used a micronutrient supplement, and for some patients with chronic renal disease or chronic pancreatitis, we had some very specific targets in the study. So step one, of course, is screening. We have to understand whether the patient is at risk. Step two is definition of individualized nutritional targets, calories, protein, micronutrients. But then also we need to have a strategy how to reach these goals, these individual goals. And so here we had an escalation algorithm, and you see level one is oral food. So we work with our team of dietitians, with our nurses, the medical staff, of course our kitchen to provide good food, but also ONS play an important role here to reach these goals. And if within 5 days we could not reach at least 75% of these goals, our algorithm told us then to escalate and use enteral or parenteral nutrition. So that's a pretty pragmatic algorithm. And of course the question is, well, will this actually be effective in reducing mortality and complications in our patients? And to understand this, we need to randomize patients so that we have 2 groups to compare the risks associated. And you see we did this randomized trial where we included a bit more than 2,000 patients, medical patients. We only had few exclusion criteria. We didn't include any surgical or ICU patients or terminally ill patients. All patients had a nutritional risk, and all patients provided written informed consent. They were randomized, and the control group, they received the best Swiss hospital food, which is pretty good food. And the intervention group, they received the algorithm that I've shown you, really trying to reach these individual goals with the team of dietitians, hospital kitchens. So it was a lot of effort to actually treat and nourish these patients. And you see this part of the trial was non-blinded because patients knew whether they would receive counseling and treatment or not. But we had blinded outcome assessments after 30 days. This is the primary outcome, and then also we did a long-term follow-up for 6 months. So, of course, the first question is, well, if we use an algorithm like this, well, can we nourish our patients? And I think it's pretty obvious, and you see here in this graph, this is the red group is the nourished group, and the blue group is the control group, and you can see from day one, you can increase the caloric intake and the protein intake if you really try your best, if you use the products, if you work with the dietitians and the hospital kitchen. And so we provide better nutritional care if we use such an algorithm. But more important than the nutritional care is the question, well, does it translate into improvements in clinical outcomes? And so this was then the most important result from our trial, because we found that there was a significant reduction in, first of all, the risk of severe complications. You see this here on the left slide. You see we had about a 4% reduction in the risk, and this comes down to a number needed to treat of 25. So for 25 patients that receive nutritional care in the hospital, we can prevent 1 severe complication. And the same was true for mortality, and you see here it's about 40. So for 40 patients that would receive nutritional care, you can prevent one death within 30 days. So the trial proved that nutritional care in the hospital is highly effective to reduce the risks of malnutrition in regard to mortality and severe complications. And I think this was a very strong result. So it's not the only trial that has looked at nutritional care. And you see here, this is a meta-analysis that was just done after the trial completion. And you see overall now there is about 6,000 patients in randomized trials. There is quite some heterogeneity, so those are mostly older trials you see up here, smaller trials with large confidence intervals, and you see the newer trials since 2015, they all had positive results. And when you now look at the totality of all these results, you see there is about a 25% reduction in the risk to die if we use nutritional care in patients in the hospital. So I think it's a very, very strong overall result. Now we also know there is some factors that are important. We know today that high protein content is important. This was also shown in this meta-analysis. This was one of the main predictors for positive outcomes. But we also know that the compliance to ONS, to the nutritional supplements, is one of the strongest factors that gives us the positive results in regard to improvements in outcomes. So overall, I think it's clear if we have a patient at risk of malnutrition, with malnutrition, if we use nutritional counseling and treatment, we can reduce some of the severe complications associated with malnutrition. The question is, well, do all these patients benefit, or do we see some patients that have specific benefits and maybe other patients that have less benefits? So can we go into more personalized nutrition? And so within our data, we also looked at some specific conditions and subgroups. And so one of them, which was interesting for us, is the question, well, does chronic disease play a role? So is it important whether your patient is a cancer patient, a heart failure patient, or a pneumonia patient? Do they all respond the same way? Now, for the heart failure patients, if you ask your colleagues from cardiology, they mostly, if you talk about nutrition, are mostly interested in the question, well, how much salt does your patient eat, right? And they tell you, well, it's important to reduce the salt. Now, the problem is, if you do reduce the salt, then the food is not going to be very good and the patient is not going to eat. And so we're going to have a problem with nutrition. And so this is a very important population because, of course, a lot of patients with polymorbidity have chronic heart failure. And so we looked very specifically in patients with chronic heart failure, whether nutrition would also be beneficial for these patients. And so we found that for this group, particularly the patients with a high nutritional risk, so these were NRS 4 and 5 or higher than 4 patients, you see that the nutritional support was a very strong predictor for survival in this patient. So the chronic heart failure patient also benefits strongly from nutritional support. A second group that was interesting for us is the cancer patients. Because again, here we have some discussions with our colleagues from oncology, and some of them tell us, well, you know, the prognosis of the cancer patients is so much driven from the cancer therapy, so nutrition is something nice to have, but it's not really important. And I don't think that's true. And we also looked at this in our data, and we found that, first of all, nutritional risk was a very strong predictor for survival, independent of tumor type, tumor treatment. So if the patient with the same type of tumor, same treatment, is malnourished, his probability that he will not survive is much increased. But second of all, we found a very similar picture that if we provide nutritional care to these patients, we can lower the mortality for the cancer patients as well. So chronic disease is important, but also what is important, or maybe important, is the question of systemic inflammation. And initially I told you that inflammation is one of these key factors that promotes malnutrition, because we know that if we are inflamed, we have no appetite. And of course the question is, well, why does our body respond in this way? If we are sick, if we have a disease, why do we not eat anymore? And this is something we see for a long time. We see it also in animals. It's a preserved pathway that inflammation seems to, and severe disease seems to interact in a negative way with nutrition, right? And often such a pathway has some logic behind it, because our body is not stupid. You know, we are all, of course, this is all mechanisms that over the years have evolved, and there seems to be some logic behind it. And we don't know exactly why inflammation promotes low appetite and low food intake, but there is more and more talk about autophagy, and which is one of these mechanisms for cell detoxification. And so we believe today that autophagy is one of the mechanisms that helps you to come through an acute disease. And by reducing food intake, the cell has more capacity to focus on detoxification. Now, this is nice if you have a healthy individual that is 2 or 3 or 4 days sick right? If he doesn't eat for a couple of days and then he starts to eat again, this is not a problem. But our chronically ill patients who always are sick and always have inflammation, so for these patients, it becomes a problem. And so in our data, we then also asked the question, well, does inflammation play a role for the intake and the benefits of nutritional care? And you see, we stratified our patients based on the inflammatory status when they enter the hospital. And so here you can see the overall patient population where you see the benefit of the intervention, the treatment. And you see the same benefit for the low inflammation and the moderate inflammation group, but we found that patients with a very high inflammatory status, so C, reactive protein higher than 100, you can see that here the two curves turned around. So in these patients, actually, we found that nutrition was not helpful anymore in reducing mortality. So this is one of the groups that seems not to respond as well to nutrition as the rest of the group. And we also looked at other markers such as albumin, and albumin, of course, we know is also associated with inflammation, and we found in our data again that albumin is a very strong prognostic marker, but it does not help us to predict treatment response. So I would advise against using albumin as a biomarker to tell us when to use nutrition, because albumin is not predictive of treatment response. So what happens when a patient then leaves the hospital? And I think that's an important question. And in our trial, we stopped the nutritional care when patients left the hospital, but we did a follow-up after 6 months to see what happens to the outcomes of these patients. And so here you see those are the 1-month outcomes where we found this difference. And when we stopped the treatment here, we saw then that after 6 months, these two curves kind of came together again. We still had a little benefit, but a lot of the benefit was lost when we stopped nutrition. And so I think it's very important also to consider continuing nutritional support beyond the hospital stay. And we currently are doing a new trial, the EFFORT-2 trial, which is actually specifically looking at this question: should we continue nutritional support in the outpatient setting? What are the benefits when we do this? And so we randomize now patients at hospital discharge and follow them long-term to see benefits in the long term of this intervention. And I think in about 2 years, we will have some interesting results here about the long-term effects. So malnutrition is highly prevalent in the population of medical inpatients. I think that's particularly true also for the geriatric patients. It is strongly associated with adverse outcomes and frailty. But we do have today data from different trials showing and proving that a systematic screening and nutritional support can improve outcomes and can counteract some of these increased risks. And I think here it's important that for most patients, we were able, with oral nutritional supplements and hospital kitchen, to reach these goals. And in very few patients, we actually had to escalate to enteral and parenteral nutrition. But I think it's important to really focus, to screen, and to use the tools that we have. So do we need more effort to improve nutritional status in the elderly patients? I think it is an effort every day, and you all that work with nutrition know that. But I think now it's really time also to act. Of course, we do need more trials, but I think we do have a lot of tools, and I think it's important now to use these tools in our clinical practice. And with that, I'd like to close here, and I'm happy to hand over to my colleague who will now talk about brain food. Thank you.
Thank you.